Well, good morning, everyone. My name is Michael Hockman. I'm an internist, primary care doctor, and the medical director for innovation at Ultimate Health Services. First of all, I want to apologize for not being able to make it to Sacramento today. In fact, I very much wanted to be there. I'm actually on vacation with my in-laws in Arrowhead, and trust me, I very much want to be there, but my wife would not permit that. But I'm very happy to speak here today, and I'm a big advocate of clinical pharmacists from the last 3 years of working with them as part of this Centers for Medicare and Innovation Challenge grant. I work at Ultimate Health Services. For those of you not familiar with Ultimate, we're a large independent community health center in Southern California. We have over 40 clinical sites, mostly primary care. We also have an independent practice association, so we take some managed care risk. We have a PACE program for all-inclusive care for the elderly, where we take full risk for a very high-risk geriatric population. So we embarked on a clinical pharmacy initiative about 3 years ago, funded by the Centers for Medicare and Medicaid Innovation Challenge grant. It was planned by our Chief Medical Officer, Dr. Martin Sirota, with Steve Chen and Jeff Joyce at USC. And I'll just say in a nutshell, we've become big advocates and fans of clinical pharmacy services. So the question is, why did we believe that clinical pharmacists could help us? So Ultimate is a mission-driven safety net organization. We want to care for an ever-growing population of safety net patients with ever-shrinking resources. And the question is, how do we overcome these barriers at a time of funding shortages? And the way that we think we can be more efficient is by embracing what's called the patient-centered medical home model of care, which many of you may have heard of. But quite simply, it's about a team-based approach so that not all of the responsibility falls on the shoulders of the primary care doctors. So some of the things we've done to promote a team-based approach at Ultimate, we've brought several licensed clinical social workers into our clinics, and now most of our clinics provide behavioral health services right there on site. We have RN case managers to manage the high-risk patients. We have health educators who can tell patients about diabetes, hypertension, lifestyle changes they need to make. And then most recently, of course, we've added clinical pharmacy services to the mix. Now, if you're like me, when you think of clinical pharmacist or pharmacists in general, you think of the retail pharmacist at CVS. But these pharmacists that we've been working with that are embedded in our clinic are very different. They're really more of chronic disease managers. The way it looks to me as a physician, primary care physician, in the old model, if I had a patient with a chronic disease like diabetes or hypertension that was out of control, I would need to see that patient 5, 6, 7 times over a 3 to 6 month period to get their chronic disease under control. So if they had diabetes and their blood sugars were out of whack and their hemoglobin A1C was in the 10 range, we really want it more like in the 8 or even less than 7 range. I'd have to see that patient a number of times, make all these medication adjustments, talk to them about lifestyle and exercise and so forth. Well, the way it works with the clinical pharmacist is actually I can refer that patient to the clinical pharmacist under a collaborative practice agreement. That pharmacist can initiate new medications, they can adjust medications, they can start that patient on insulin. They, of course, communicate this all with me, but they take care of it. And then when the patient comes back to me 3 to 4 months later when they've graduated from the program, in many cases their disease is under much better control. And that allows me as the primary care doctor to manage their depression and find out why they were in the hospital and how everything intersects with each other. So it really offloads a lot of the work that allows me to take care of a larger panel of patients and to deal with some of the more complex issues that I went to medical school to deal with. Okay, another reason that we did this, and hopefully there aren't too many doctors in this room, is that doctors don't always like to follow evidence-based guidelines. So one example of that is the new cholesterol guidelines recommend that statins are really the best medication for managing cholesterol because they're the only medications that actually reduce heart attacks and strokes. Some of the other medications like gemfibrozol lower the numbers, but they don't impact those hard outcomes that are important to patients. Well, we find that still many of our doctors, despite the evidence, like the medications they're used to using. And we expected the pharmacist would be better, and we found this very much to be the case. So a much higher percentage of our pharmacists compared to doctors are using the evidence-based statins to manage cholesterol. So we've gotten some very substantial quality benefits from having the pharmacists on board. Just to give you an example, and I believe Steve is going to be showing you this data as well, in terms of diabetes, the pharmacists are doing 11% better than doctors at getting the hemoglobin A1C control, and they're doing about 9.3% better than our doctors at getting blood pressure under control. So not only are they doing as well as doctors, but they're actually doing better than doctors. And if you know the personality differences between doctors and pharmacists, that may not be such a big surprise. Okay, overcoming anxiety. So when we brought pharmacists to the team, a lot of the doctors had a lot of questions and concerns. The first was, can pharmacists do this? Can they initiate medications, adjust medications? Can they do this safely? And a substantial amount of data from Kaiser, the VA, Cedars-Sinai, and many other places have substantiated that they can do this safely, and we've reaffirmed that with our experience at Ultimed. There was also a lot of concern, will they communicate with us? Well, they've done such a good job communicating with us that many of the doctors have relatively quickly told the pharmacist to stop telling me every time you make a medication adjustment. But of course, the best thing about a team-based approach is it's very important to do this communication. So the pharmacists have not let up. They've continued to communicate with us, and I think they've developed a really good team relationship and have been able to take better care of the patients because of that. Another question often comes up, why did I go to medical school if pharmacists can initiate and adjust medications and so forth? And my feeling is that's exactly why I did go to medical school, because if there's something that a pharmacist can do just as well or better than me, that enables me to do some of the stuff like managing complex situations, multiple chronic diseases, the post-hospital care, and so forth, that I did go to medical school to do. Okay, so the major challenge, and again, not to steal Steve's thunder if he hasn't shown the data yet, this program was a win-win-win all around. As I mentioned, it improved our quality scores. It really improved our physician satisfaction. So when the program ended, after the grant ended in July, after 3 years, there was an outcry from the doctors. They wanted to continue it, that they had become dependent on having the pharmacist there. So provider physician satisfaction was very high with the pharmacists. Patient satisfaction was off the chart. So our CEO often says that he gets more thank you notes from the pharmacist patients than from any of the other patients in the organization. And then finally, we've seen about a 10% reduction in ER and hospital utilization. There's very few things in medicine that improve doctor satisfaction, patient satisfaction, quality scores, and keep patients out of the ER and hospital. So this should be a slam dunk to continue, right? Well, of course, it's not. And the problem is that clinical pharmacy services are not reimbursed for in many settings, including community health centers, because pharmacists are not billable providers at FQHCs like Ultimed. And so what's the solution to this? Well, one possibility is that we could make pharmacists billable providers, but I actually think the longer term better answer is that as organizations like Ultimed increasingly take on financial risk for patients and we get paid a per member per month capitated payment, then we're going to have the flexibility to use those dollars as we see fit. And I certainly think that in that budget, we've convinced ourselves that some of those dollars should be used to support clinical pharmacists. So that's about all I wanted to cover. Thanks for listening. And if you have any questions, my email address is mhochman, mhochman, @la.ultimed.org. And I'm sure if you didn't catch that, Steve can give it to you. So thanks again.